It's been brilliant to see so many familiar faces from this morning's discussions in and around the platform. Up next, I'll be handing over to our next keynote speaker of the day, Claudia Paoloni, a consultant anaesthetist at University Hospitals Bristol and president of the Hospital Consultants and Specialists Association. Claudia and her colleagues at the HCSA were vocal during the pandemic in raising concerns around IPC guidance and PPE supply. They've called for better, more consistent guidance to ensure that staff are kept safe and given appropriate equipment. Over to you, Claudia. The virtual stage now is yours.
Thank you, Helen. Right, so first ourselves. We are the HCSA, and I'm going to be talking to you about nosocomial infection. And that question, should we actually be blaming the staff, is easy to do. Next slide, please. So we're a professional association and trade union representing and advising hospital doctors in the UK in both the private sector and the NHS. And we work with NHS England and employers to ensure the safe COVID pandemic response for our patients and staff, but also with other matters outside of COVID. Next slide, please. So let's look at some facts and some basic data. Now, this data was achieved from Freedom of Information sent out to many NHS trusts throughout England, and it was found that 1 in 7 patients treated with COVID likely acquired it in hospitals between the 1st of August 2020 and the 21st of March of 2021, which equated to a 15% proportion. That was 40,600 patients. And there was regional difference with that. So the Northwest had double the rate compared to London. And we need to think about that when we go further on in the slides. But is this unusual? Because when there was some research modelling done by King's College and Cardiff University and Guy's and Thomas's London, they found that in 2016-2017, healthcare acquired infections affecting out of 13.8 million adult general hospital and teaching hospital inpatients, 4.7% were achieved within that time frame. So it was a 4.7% infection rate. That's 22,800 people died from hospital-acquired infections. Now, with the COVID, that they found that there's 8,747 deaths of hospital-acquired COVID. That's a 27% death rate. Next slide, please. Now, this has an economic cost. If you take that 13.8 million adult inpatient admissions, that actually equated to 653,000 healthcare acquired infections. When you look at how many occupied bed days that's 5.6 million. And we already have a very limited capacity. And what's also very significant when we have such staffing shortages is that it also equated to 62,500 staff days of absenteeism and cost the government and the NHS 2.1 billion. Now, when you added in all the specialist NHS hospitals as well, because the ones above were just the teaching hospitals and district hospitals, it actually cost 2.7 billion and equated to 79,700 days of staff absenteeism. That's a huge amount of money. Already to date with COVID, we've spent 92 billion in the NHS with a total cost of 349 billion. So this is significant amounts of money that we're talking about. Next slide, please. And of course, there's a patient cost. If you don't get it right, if you're not prepared for a pandemic and the infection is allowed to let rip, you end up with this situation that we're currently finding ourselves in. 5 million patients on waiting lists, which is the highest since the records began in 5 million patients since 2007. And more than 400,000 patients waiting greater than 52 weeks. Now, doctors are estimating it's a minimum of 18 months to recover. Some say many, many more years than that. But the question still remains, are the staff to blame? We've had suggestion made that it's actually the staff that are infecting the patients. Next slide, please. But I think we need to look at all the influencing factors to make that call, really. So hospital capacity, that's one of the issues. Now, if you look at ourselves in the UK and compare ourselves to the rest of the European community, we have the second least hospital beds per 100,000 of the population. We have 250 beds per 100,000. If you compare that to Germany, which has 800 beds per 100,000 population. Now, it's been known and identified even prior to the pandemic that the NHS general and acute beds base has fallen, and especially in the first quarter from 100,000 from the 2 years prior to that. And it's been pointed out that we've been in the sustaining decline of hospital capacity, and that we've been standing with a shortage of at least 8,000 beds of what we ideally need. And that was pre-pandemic. As soon as you started adding in the restrictions we needed to do with social distancing and the spacing of patients and the different areas of isolation zones, that's another additional 10 to 30% capacity loss. Next slide. Then the estate facilities themselves. And I know some of the previous panelists and speakers have mentioned some of the estates factors, but we have a whole range of hospitals. We have old, we have new. We have space within hospital very limited, often cluttered because we have lack of storage. That we resulted in corridor care, which meant we were even more pressed for space. We have insufficient isolation areas. Estate modifications needed to be done. We had to put up screens at very short notice. We need to create donning and doffing areas. We have complex hospital footprints, which made flow pathways really difficult. And we had ventilation problems. Old versus new hospitals. Just because they were new hospitals didn't mean they had better ventilation than the old hospitals. In fact, some of the old hospitals with their rattly windows might have even been better off. We had congested A&Es. We're short for space. We're in very small footprints. We had ambulances unable to unload their patients. So we had paramedics stuck in ambulances, tin boxes with coughing patients for hours on end with minimal protection. Next slide, please. So the next thing we have to look at is the personal protection equipment. And I'm sure you will see some of these headlines and remember them. So despite the claims that there was never a national shortage, we certainly had difficulties getting the supply to the right places. It wasn't very helpful, we didn't find, when there was an allegation early on in April that perhaps it was due to the misuse of the PPE, rather than just down to the inadequate stock levels. But there were logistic problems as well with distribution, trying to get them from the central stores. Next slide, please. And we also had at local levels stock theft. There were patients and relatives that were then finding that they couldn't use hand sanitizer as they came in. We didn't have PPE for our staff because whole stock cupboards were just disappearing in the panic as COVID arrived. So consideration has to be made around how you store and retain your equipment. Accessibility of PPE by staff was very variable. So those that felt vulnerable, wanted to have masks, were at times told they couldn't. They shouldn't frighten the patients. They shouldn't frighten people by wearing their full PPE. That's not acceptable. And they had problems with actually ensuring that the appropriate standard was required, because in the mad rush of trying to do last minute ordering, we had arrivals into the country of equipment that wasn't fit for purpose. And we also had out of date equipment being used that with just new labels stuck on top. And when we surveyed our members in 2020, 44.5% of staff found that they had to source their own PPE at the beginning of the pandemic. Next slide. And then we, as Helen kindly said, we got involved in trying to address some of the infection control measures because obviously they are guided and they come out of Public Health England. And there's been a lot of discussion, firstly, of whether this was a droplet versus an aerosol transmitted disease. So was it contact versus inhalation? And that has led to continued debate, and despite increasing evidence, has still remained at the point of that it's not an aerosolized virus. However, that with conflicting other evidence that in fact it is. So that has been a problem, and that has resulted in many groups such as the AGP Alliance, ENT UK, even the Resuscitation Council UK, actually taking task with this and trying to get amendments to the guidance to recognise how that individual who's putting a nasogastric tube in someone who may or may not have COVID and who's coughing and spluttering whilst the NG tube is being inserted could actually be transmitting disease to them as well. So there was the debate about PPE and whether people should be wearing the high protection FFP3 masks. But there's always been a supply limitation around that, which inevitably is affecting choices. Patient zoning, so the red, green, amber zones, that also had impact on capacity. Social distancing needs for staff and patients. Coffee rooms needing to be adequate so that staff could actually take their PPE off and have a cup of coffee and a needed break. Staff capacity. Now, one of the problems when you start doffing, donning, and having aerosol generating procedures, you need double teams. So our staffing that was already short was further pressurized. And then the public compliance, the face masks and social distancing that we relied on people to do in the community to try and keep the community levels down, resulting in lockdowns. Next slide, please. So staff confidence is a big thing. Which of these two images would give you more confidence if you were wearing the PPE? The one on the left, who's from the UK, or the one on the right, who's in France? So you have to bear in mind the staff were seeing these images from elsewhere in Europe and having to compare with what they were being given to wear. In our survey, 87% of respondents felt they felt unsafe at work because of their PPE. Personal risk assessments had to be introduced, and home working and shielding was introduced. Unrestricted PPE would have also given more reassurance if it was available for their staff based on risk assessment or even just for their own staff confidence. Next slide, please. Then we had the testing and isolation. Now, clearly, there was already evidence that their patients had asymptomatic transmission. WHO stated that in April 28th, when they actually said that for the 2 or 3 days before showing symptoms, they could already be transmitting disease. But that took a long while to be picked up on. Then we had the problem with the lack of capacity in the testing and the false negatives. And of course, in the recent Department of Health review of the care of the elderly in the COVID pandemic, where it states only 1.6% of the infections could be associated with hospital discharges, we have to bear in mind that that was actually at the time when no testing was being done. So the data really isn't there to be able to make that judgment. Testing was slow. It's now in place. It needed to be there much earlier on. Cambridge study in April 2021 suggests that in fact 3% of NHS hospital staff were knowingly infected with COVID, which is suggesting that 15,000 of 500,000 patient-facing workers may have been infected and working at the time, which of course puts their colleagues at risk and patients at risk. And despite PPE, it has also been shown that the red area staff, so those in known COVID-confirmed areas, were 3 times more likely to test positive than staff in green areas, suggesting that, in fact, the PPE was inadequate. For in areas such as in Asia, where they have managed to have no healthcare worker infections, they use much stricter and higher protection levels. And it was only in October 2020 when we started introducing twice-weekly lateral flow tests for the staff. Next slide, please. And of course, the community rate of infection has an impact. At the peak of the second wave, the 7-day average was 59,660 a day. We still had schools open, and whereas initially there was the indication that children were not transmitting, but of course that's difficult to know when you weren't testing at the time. And we were very late to lockdowns, and we didn't introduce fire breaks, one of the things that we had been calling for. Face coverings, in fact, were only mandated in shops in 24th of July. The pandemic really hit our shores back in March, at the very latest, if you want to give a guesstimate. And the daily use, delay of wearing masks in all hospital areas only made it on the 15th of June. And you have to remember that staff are also part of the community, so there will be that risk that they will be contracting and bringing into the hospitals. Next slide, please. So what is the impact on staff? Well, the impact on staff is that we saw a massive infections rate go up within our own staff and a staff absenteeism going on. Now, in the 10 years pre-pandemic, there was approximately a 4% sickness absence rate. That's the green line, so that's the average line. But when COVID hit, it went up to 7%, and you can see that peak in the peak time of the infection. Now, in the 10 years previously, that's actually equivalent to 50,000 full-time equivalents off per month. That's huge when you're already short of staff. And in the COVID pandemic, we've also had 1,500 healthcare workers who have died. We've had staff that have lost their training or been redeployed and put into areas that they weren't very confident in. And this staff also had financial costs. So 4 out of 10 of our doctors in our survey that responded found that they had additional costs in either additional PPE, loss of income, extra childcare, hotel costs to separate themselves from their families. And they also suffered delayed payments from extra work. So all these things, when you're looking at infection control, matter because it impacts on the overall picture. Next slide, please. There was obviously the separation from staff from family with that and the impact that has. The worry about vulnerable family members and taking the infection home. Physical exhaustion, and we all know about the mental and health concerns that we have. And also the emotional blackmail that some felt obliged to carry on working because of the shortage in staff. Next slide, please. The mental well-being, as I said, in the Royal College of Physicians survey, April 2021, 69% of respondents feel exhausted. 31 respondents felt demoralized. And 2/3 still hadn't had no discussion with their employer about time off to recuperate. And you have to ask yourself, the idea of buying back annual leave so that we can do a COVID recovery is a bit of a moral dilemma. Next slide, please. Vaccinations. So we recently would have heard about the concerns about whether we should be making healthcare workers mandatory for them to have the COVID vaccination. I'd like to put some context into that because actually with the England flu vaccination uptake, normally we have an uptake only of about 35 to 55%. Whereas with the COVID vaccine, we've had a 93% overall. So this is a high take up. In normal years, 23% of our healthcare workers may in fact become infected with flu, of which 28 to 60% are asymptomatic. So they are a vector for transmission. And it is something I would suggest that needs to be thought of going forwards post this pandemic and before the next pandemic as actually significant impact on our staff levels within the trusts and hospitals and healthcare working environments. Ironically, when we have the debate about mandatory and voluntary vaccination, it was actually the staff that were asking to have the full vaccinations without delays right at the beginning. So that is somewhat ironic when this is now a discussion, should we have made it mandatory? Next slide, please. So I would say for future infections and future pandemic planning, and even just the next flu of the next winter, be prepared. Exercise Cygnus of 2017, which was looking at the simulation of an influenza pandemic, showed that there were areas that needed improving. Managing surge capacity, understanding public reactions and boosting capacity in care homes, let alone the PPE issue. And those lessons and recommendations did not get taken up. So I would say to you, be prepared, but most of all, take care of your most precious resource. That is your staff. Thank you. Next slide.
and make into the spotlight the need for better, more thorough planning for similar situations in the future. Pandemics didn't begin with COVID and of course won't end with it either. It's imperative our health services, public sector and government bodies work together, collaborate, prepare and collectively tackle major incidents of infection. And hopefully many valuable have been discussing greater depth. To welcome our guests. We've got Motolani Awokoya, Health Protection Practitioner for Public Health England, Jane O'Donnell, Head of Health Protection Commissioning and Public Health at Kirklees Council, and James Budd, Quality Assurance and Infection Prevention Lead, Littlehampton and Rustington Housing Society. You know the drill by now, just with all of our other panels today. Please take advantage of our live Q&A function if you've got questions for our guests. The team behind the scenes is working to moderate and star the questions that can put as many to the guests as possible. And as you know, I do like this to be a conversation where possible. So, panelists, and I'd like to start off by asking all of you, if I may, your thoughts on how the pandemic was handled and managed. And to start perhaps with you, Motolani, that would be lovely.
Hi, hello everyone. So you want my thoughts on how the pandemic was managed?
Yeah, how it was managed and how it was handled, and following on from all those things that Claudia said.
All right. So obviously there will be a reaction that will come from the hospital setting, which is what we've had most of today, and there will also be a reaction from what has come from the Public Health Department of England. And I can only speak from the public health angle because that's the experience I've had in the past 1 year. And in the past 1 year, usually data is reported to us through various means. And one of the means was the test and trace system. And we also get reports directly from the laboratories. And those are the two major routes where we get reports from. And once we get information from those two systems, basically, we try and put the ends of it knots together and see and find out what to do at that instance. And of course, that has to be in line with the government guideline of the day. So when we've tied the ends together and we discover that there's an outbreak in a particular setting, I take, for example, in a care home or in a hospital setting, then we have to convene an outbreak meeting to address the outbreak. And the whole aim is to, first of all, to identify the source of the outbreak. When you identify the source of the outbreak, it makes more sense on how to manage the case. In the instance where the source is not found out, it makes it a little tricky. So once the source of the outbreak is identified, then you want to find out the contact, and that's where contact tracing comes in. So you want to find out how many people must have been in contact with the index case. And when you find that out, you can give your public health advice. And in cases where you want to do further tests, you also want to test just to make sure that there's no forward or onward transmission of the virus within the setting. And this setting I'm talking about, a care home. So basically that was our role. I mean, I'm using a care home as an example because that was much of what I did in the past 1 year. So basically that was what our role, to identify an outbreak even before the public goes about it, and to ensure that not many people, or to ensure that there's no forward transmission of the virus within the setting in question. So that has been my role in the past year. Were there challenges? Definitely there were challenges. Sometimes we had data that was reported to that might not meet the definition of an outbreak. Sometimes we speak to people who perhaps due to frustration, due to the fact that they've been told to isolate at home for 10 or 14 days, and then so they find it difficult to isolate, or they just don't want to engage with public health. So those are some of the frustrations that we had at that time. Obviously, it's improved over the period of time. And then I know we're back to that stage where people are actually frustrated when they hear they have to isolate at home for so number of days, and then the new variants. So those are the frustrations that we had. And of course, we have to maintain our cool because we know that people did not have much of the information. So when we speak to them, or when we have contact to speak with people or to management settings, we have to address all the frustrations and just to ensure that there's no forward transmission of the virus. Of course, we feel that sometimes, and that's when the virus increases, but not because we failed in our job, but because the advice we give to people, sometimes they will not want to bear with it. So it's not a failure on the part of public health. I think it's a failure that all of us have to admit, both public health and the general community. And of course, we've succeeded so many times. And then the success, of my own opinion, actually outweighs the failure that we've had. So that's been my role in the past 1 year, in summary.
That was a fantastic summary there. Yeah. I feel I really know what public health have been doing there.
Well,
Jane,
it's more.
Jane, I'd love to know what's been happening at Kirklees and whether maybe you can give us some examples of what you've been dealing with in your neck of the wood.
Yeah. Welcome everyone, and nice to be part of the panel this afternoon. So we're very much in Kirklees, it's been much of a whole systems approach, and you've probably seen in the media we've dealt with a lot of workplace outbreaks and being able to support those businesses. Obviously, as part of that, obviously a timely response to obviously break the chain of transmission is paramount. So built up very close relationships with a number of businesses, and because of obviously sitting in public health, and we have infection prevention and control team, emergency planning, obviously environmental health is part of public protection. We've been able to do a really timely response. I think comms is obviously been key as well, in the fact that we've built up relationships with them. We've been able to offer advice and support. As part of our IMTs, we've included the health and safety executive. We've also included our legal team, because obviously working with businesses, when you've got large outbreaks, it may obviously impacts on their financial gain as well. And obviously they want to continue to support that, they can continue with their businesses. So we've worked at times with business to look at staggered ways of working. We've gone in and done support visits, looking at the layout of the building with infection prevention and control and environmental health and safety exec as well. Also, that then, as we've obviously been able to then share that learning with other businesses, and obviously put that learning also into some other settings as well, because in Kirklees we've worked very closely with schools as well to manage outbreaks as well. As you know, we were one of the areas which was identified as an area with an enhanced response package. So we've actually just been doing search testing, which the local communities have been so receptive to. And we've been able to have those important conversations with our communities, not just about the importance of getting testing, but obviously about the importance of getting your vaccine as well. So being able to have those doorstep conversations with our communities. And it's also enabled us to bring pop-up vaccine clinics to those communities and to those workplaces. And the actual numbers what have attended those vaccine pop-up clinics has been absolutely tremendous. We've also worked and will continue to do some targeted testing in some of those areas, working with obviously priority testing using the lateral flow tests. Obviously, as areas, local authority areas, we have to put plans in place for looking to the future about priority testing for focus groups. So that is work what we'll continue to do with our local communities, and also being able to disseminate that learning from the outbreaks as well to other workplace settings. And we've been able to do that via briefings, letters out to businesses, but also, as I said, the support visits that environmental health have done, IPC, and the health and safety executive as well. So we've also often used the common exposure data, what we receive from Public Health England, to be able to identify clusters, so be able to manage that before we end up with the large scale outbreaks as well. We also in Kirklees have a door knocking service what goes and visits all positive cases, just to ensure that they're aware of the isolation support payments what are available, access to welfare, because not everybody has somebody who can go and do the shopping or obviously pick up their prescriptions. So ensuring that support is available to them to ensure that they can isolate throughout those 10 days.
It sounds like so much has been going on at Kirklees Council, and a lot that, you know, other people will be able to learn from. Poor old James is sitting there. James, with your housing society hat on, you know, as an organisation, I'm sure, like my other two guests, you've been full on as well. How did you react to the outbreak? How have you maintained and kept, you know, residents safe and well?
It's been busy. So Littlehampton and Rustington Housing Society, we have a care home called Rustington Hall. So we are a 62-bed nursing and residential care home. So I deal with the quality assurance and infection control for that sector. But yeah, the pandemic, it's the barrage of information, but obviously maintaining resident safety, staff safety whilst remaining compliant. So due to all the changes that are happening so rapidly, I've had to adjust practically daily, say, right, that policy we've been adapted, you know, we've been abiding by this policy, X, Y, and Z. That's been completely drawn out. This is now the existing policies. Yeah, it's been rather busy, but then also, you know, us looking after your residents, also looking after the families. So a lot of things regarding consent. So with the vaccinations happening, we have to deal with the consent for vaccinations, consent to all the testing. Sorry, I'm getting a bit tongue-tied. All the testing, and also whilst being physically here. So I'm actually on site 5 days a week. So even whilst the outbreak, which we unfortunately did have towards Christmas time, I was actually on the floor helping the carers, being a part of the building, staying overnight. So it's almost, I was in the thick of it, essentially.
How did, James, may I just ask, how did your residents do? Did you manage to keep everybody safe? And also, how did they cope with the fact that, you know, visitors were restricted or stopped at some point? I always feel that must be very difficult, you know, in care homes when, you know, people reach a certain age, all this is happening around them, and they can't have a hug or be with loved ones when some of them, you know, are very winding down towards the end of their days.
Yeah, so obviously end of life, so residents who were receiving end of life care would still be permitted visitors under a risk assessment. We still did not deny that. And apart from that, there was a slight change in policy. I believe it must have been towards the tail end of last year. As well, in regards to communication, obviously there was a window visits that were occurring. We purchased multiple iPads and tablets so that we could communicate with families, do FaceTimes. We had a booking system, which we still do, families who are a little bit further away. Obviously, the booking systems now relate to indoor visits and outdoor visits. Yeah, keeping safe, obviously, with regards to our outbreak, our residents did isolate in their rooms during outbreaks, but we're quite lucky where our building has 27 different fire zones. So we were able to, I was able to sort of isolate those certain areas. And then in regards to the decontamination plan, we targeted those areas in timings with the isolation periods so that the building would systematically become safer, if that makes sense. Yeah.
Talking, we were talking earlier, Motolani, with the GPs about how GP surgery practices had, you know, made changes in 2 to 3 weeks, technology-wise, that may well have taken 2 to 3 decades, you know, before we found ourselves in this situation. And, you know, data, I presume, is key in a pandemic. And can you tell us, Motolani, about the source and importance of data in outbreak management, and what should that data?
Yeah, like you said, data is key, and we work with data. Without data, perhaps there'll be no public health. And just like the GP said, I think we worked on the track and trace system, and we also had our own local software that we used. And at the time where there were so many cases, we had to go into the track and trace system to start to look for outbreak in settings, in priority settings, like James said. We had to go look for care homes that had outbreaks. We had to go look for schools that had outbreaks. And in essence, it looked like looking for a pin in a haystack, because we were trying to work ahead of the data source. So it was really a Herculean task, not because the system was not working well, but because we wanted to get ahead of times to go and look for data. So data finding was a very important part of our job at the time. And I think we did a very good job in sourcing for data. And it meant that we identified outbreaks quickly and faster, and we're able to pass it on and manage it effectively. So I think that was one of the things that we did in the London Public Health Department. And then obviously we also had to communicate with the local authority, and I'm sure Jane can bear with witness, because once we identify the source of the outbreak, immediately we inform the local authority to tell them there's an outbreak here, and we convene an incident management team where we want to manage it as soon as possible. Like I said earlier on, the essence of the whole job is to ensure that the wider public is protected from onward transmission of the novel virus, which I think, to be honest, we did, and we achieved a huge success. Can there be improvement? At this time, I can't say, because we've not been able to do, I have not seen an audit of what it could be. But if I look at my own role and what we did, and if we're able to identify an outbreak in the quickest time possible, I think we did the best of our abilities to ensure that outbreaks were detected in good time.
Jane, Nikki says, our practice did COVID welfare checks when the pandemic started, but unfortunately, due to our work, able to continue doing these. They were very helpful, isolating without any social help. And I just wondered, Jane, how do we create a more approach, if you like, to responding to outbreaks and major incidents? Because it sounds like, you know, you were on such a journey. How do we make sure that we sort of benefit and share the information and make sure that we're so much better, you know, prepared, you know, next time round?
Yeah, it's definitely learning from each outbreak and sharing that learning. What we've obviously in the local authority, we've actually employed what we call COVID support officers. So they've actually been able to go and do some of the welfare checks as well on our residents. We've obviously very much done a collaboration with our primary care colleagues as well to see who's really best pleased. So where we're looking at sort of some of the care home outbreaks, IPC have obviously supported, but the care home support team from our local providers has also gone in and provided. So it's a sort of a whole system approach to ensuring the safety of the residents within those care homes. So I think it's continual learning and going forward, testing your plans as well. We obviously put together a search testing plan before Kirklees became an area of concern. We actually exercised that. We've reviewed it during the month-long search testing, and we'll continue to review it. So I think it's as well as that, continually testing your plans and making sure that it is a whole system approach. You cannot work in silos with pandemics. You've got to ensure, and you've got to bring your communities along to ensure that they embrace those messages, those key public health messages, to obviously break the chain of transmission.
Just looking at the questions, Donna makes a comment. Just a steep decline in our patients with dementia due to the impact of isolation and changes in routine. Is that something that you've noticed with the residents you look after?
Regarding those who do have cognitive decline or dementia, but yeah, I think especially during the pandemic, where there was the obviously isolation periods and the walking with purpose, it's obviously quite challenging for other care homes, or obviously I can only speak for us, but obviously other care homes may not have facilities to be able to do create risk assessments regarding walking with purpose. Luckily, we were able to do that because we've got outside courtyard areas which do link onto bedrooms, and we do have an isolated activity suite which we did use as well. So to keep, and also we've got a wellbeing team as well, who would do one-to-one visits in rooms to keep people active and keep make sure their wellbeing is also looked after.
And James, was adequate support provided, do you think, by governing bodies and community professionals?
with regards to community professionals, so we work closely with West Sussex County Council and obviously their Public Health England. We had so much support. We had the crisis team. Unfortunately, we did have, during our outbreak, we did lose quite a large percentage of staff. The crisis team were fantastic. Our local CQC inspector, but also the lady who looks after our specific area, she was fantastic. Always at the end of an email. Yeah, no, I was really, really impressed. And obviously we've got an assigned local GP surgery. So they would come by and do obviously once a week check-ins to see if we're okay. Yeah, I was really impressed, actually. I think that we did feel quite a lot of support.
That's really nice to hear, James. Motolani, what role do government organisations and public sector, local government and social care particularly, have in responding to infection control and outbreaks?
Yeah, so obviously it was a collaboratory effort. We couldn't work alone because we're not local. So we obviously had to involve the local authority. And like again, Dean can bear me witness. And obviously we also had to involve organizations like the CCG, because we want to also ensure that the care homes, like James has said, have their own local policy where they can manage an outbreak. And should they need support of any sort, then we also work hand in hand to ensure that they have all the supports that they needed. Obviously, the local authority had a huge part to play. If they needed some more staff to cover shifts, if they needed more supply of PPEs, then local authorities, when we have spoken with them, can be able to work also hand in hand with the care homes to provide the support that they needed. So obviously, like I said, it's a collaboratory effort. We couldn't have done it by ourselves. And even in my own team, we also have hierarchies. When I see that I have difficulty, I can pass it on to my consultants, and who also can escalate it and ensure that the case is dealt with as soon as possible. So yeah, for example, I dealt with care homes a lot during the pandemic, so I can say for care homes. And James will bear witness again to say that they received a huge level of support. We helped with escalating test regimens and also receiving test results as soon as possible, because we can only find out cases when they are tested as at when due. So those are ways where we plugged in to ensure that there was support to the wider community.
I know one example that you've quoted, information was received on multiple cases in a large food manufacturing business. Can you share that story with us, and what were the initial steps taken and the outcome of that? How did you handle all that?
Well, obviously we saw from a timeline, we saw that there was a number of cases within a food manufacturing business. So obviously we then started to build up a relationship, particularly with the HR manager and also the chief operating officer for that, which was by Public Health England colleagues and members of my team, as well as our director of public health. We had lots of conversations with them and involved them in what we were proposing as those control measures after we'd done those site visits. And because obviously what we did is we brought in a mobile testing unit and offered testing to all those employees, which resulted in having to close down the business voluntary. We'd never in any of this have had to take out any directions, any legislative directions to enforce closures. So we worked closely with them and then looked at staggering the return back with the different isolation periods, and obviously made recommendations, because what we found through some of the large outbreaks within workplaces, it was car sharing, it was also particularly smoke shelters, changing facilities. They were tending to be large businesses where it was noisy, so people were shouting, so looking at other ways that they could communicate with one another. And we've continued to have that dialogue with these businesses after the outbreak has actually concluded. We've continued to have that dialogue about if they've had a case, have they identified the relevant contacts. Obviously, some of these people live in homes of HMOs, so again, the impact on their families for actually having to isolate, and obviously offer of isolation payments, advice of where they get the isolation payments. going forward. But it's very, very much that two-way process of communication.
Oh, and what protocols, take place once you've got that information and the intelligence gathered, if you like?
Well, obviously, we start with our incident management team meeting and pulling all that together and agree the control measures. But then, obviously, because we're in a local authority, we also ensure that our outbreak control board is aware of the outbreak and again what control measures. Our local councillors as well, because again they're best placed to have those dialogues with the local community. We've always been very proactive with the media so that they're aware of what is happening, and also with our local communities as well. So it's very much obviously ensuring that our local trust providers are aware, because some of these obviously could have related to being inpatients and have an impact on that organisation, or if there was care homes in that vicinity, again having that dialogue with our CCGs and adult social care providers so that they were aware and obviously could ensure that we're really, really stringent with their IPC during the course, and have continued to do so. Everyone's just worked very closely and very collaboratively throughout.
James, do you feel that we're in a position now, 18 months on, that we're in a stronger position, if you like, to tackle anything that COVID may throw at us, or indeed any other virus might throw at us in the future?
Yeah, so obviously with the introduction of the NHS supply chain, that's obviously helped care homes tremendously. I feel we're in a better position. I think the knowledge is there. I think as much as infection control has always been important within care homes, it's now obviously been brought a bit further into the forefront. I think people are a lot more aware of what they're doing, and also, they're asking the questions, which is quite nice. So they'll come to me and say, oh, this has happened, or I've done this with a certain resident. What do you think? Do you think we could do this a different way? I think we are, and obviously with the testing protocols moving forward. So, for example, we had there was an outbreak at a local school. We did staff testing for 2 weeks running before every member of staff, for every shift, every member of staff was tested before coming onto duty. As luckily we got an off-site premise which we do our testing on. So things like that, having those interventions in place just to give you that extra piece of safety and know that your residents are going to be a lot more safer, and that those risks aren't necessarily risks anymore, it's just precautions.
Motolani, what do you think, looking back over the last 18 months, what are the key lessons or that you will take away from this?
The key lesson that I'll take away from this is that we live in a period of uncertainty. We don't know if there's going to be another pandemic or another respiratory virus in God knows how many years to come. And I think the key lesson, which I think the government has also learned and they're working towards, is to get prepared for the eventuality. If it's going to happen again, are we going to have another pandemic? And I think the government has taken that on board, and I believe they're really working on that. We have to be prepared. We will not be caught unawares anymore. I think that's the key lesson that I've learned personally. And I think also from what we can see in the news and from the press briefings, that's a lesson that the government has also learned. So we have to be prepared.
Jane, final thought to you. Have you been on a personal learning journey with all this too?
I think, yes, quite definitely. I think leadership is key to me in this. We've developed more escalation protocols during the pandemic, and is everything a key to managing outbreaks is that comms. It's paramount. If you do a debrief, some of the lessons learned are always comms.
Brilliant. It's been great to talk to the three of you today, and I think it was a great way to end our day. You all brought such valuable insight to the table. So thank you for making time, and thank you for the notes you sent me in advance about what each of you do, which are always much appreciated. So thank you to Motolani, James and Jane, brilliant panelists, and as I say, brought an awful lot to the table. With that, we're going to draw to a close on what has been a fantastic day of guests and networking across our NHE 365 platform, covering all aspects of infection prevention and control. As mentioned throughout the show, all of today's content will be available to view on demand within the platform at your leisure within the next 24 to 48 hours. Equally, our networking tools remain open year-round with an ever-growing community of registered forward thinkers. I hope you've enjoyed today, and I really look forward to seeing many of you back again for future events we host throughout the year. If you're a winner in our gamification challenge, the team from NHE will be in touch to discuss the prize options. As a reminder, those in first, second and third in our gamification leaderboard will have the choice of 3 prizes of equivalent value. So you can either pick the Amazon vouchers, donate some money to a charity of your choosing, or plant an equivalent number of trees. Today's event was CPD certified with 1 CPD point earned for every hour of content watched. Our team will collate this information and certificates to you following the event. And just before we go, I'd like to extend a special thank you to our brilliant team behind the scenes at National Health Executive, who, believe me, have worked tirelessly, both today and in the run-up, to ensure that we could put on such a great event. I think we've all benefited from their hard work and fabulous guests. From me and everyone at NHE 365, thank you for attending and for your company. I hope to see many of you, and perhaps some of your colleagues too, at our next NHE 365 event, all around a net zero NHS, and that's taking place on August the 25th. So have a great evening, and thanks for having me.